Thank you very much, John, for the introduction. Thank you for inviting me back again this year. And I'm delighted to provide an update on the renoprotective effects of SGLT2 inhibitors. And unlike last year, I've actually got a trial to talk about this year, the Credence study, which you heard a little bit about this morning. So relevant disclosures are listed in this slide. So this is the typical patient I'll get referred from GPs in this area, actually, in Camden. I work at the Royal Free Hospital, as you probably gather from the first slide. And we have a virtual referral system whereby GPs can send us details about a patient. We can log into their database, the EMIS web system. We can view the patient on their system. We can plot the GFR. We can look at all the blood pressures. We can look at the therapies. And this is a fairly typical sort of patient that we get referred, 67-year-old Caucasian male who's overweight, as you can see, has had their diabetes for 10 years. And I know that they've got microvascular disease because they've had laser treatment to their eyes. The blood pressure is well controlled. GP's doing a great job with blood pressure control. Same with glycemic control, HbA1c of 7.8% in the old currency, well controlled, and well controlled over time. But despite that, the eGFR has dropped to 39 mils per minute, corrected for body surface area, and a year ago, that GFR was 48 mils per minute. So this patient's lost almost 10 mil per minute of GFR in a year, and the GP is understandably worried and wants to know if there's anything else that can be done. Now, the patient I know is in a high-risk category because this patient also has albuminuria. And we now measure as standard the ratio of albumin to creatinine in the urine on a spot sample collected at any time of day or night. And this patient's spot albumin to creatinine ratio is 65 milligram per millimole, the upper normal being 3. So this patient has got albuminuria, and this puts this patient into a high-risk group. The patient's on a beta blocker. They're on a maximum dose of ACE or ARB, which is what we like to see in these patients with diabetes and chronic kidney disease. Notice I didn't say diabetic nephropathy because we haven't made that diagnosis, but the patient has diabetes and chronic kidney disease. The patient's on amlodipine, a cautious use of metformin, Professor Bailey, there. 500 milligram BD, okay, GFR 39, okay, good. And 80 milligrams BD of gliclazide with a DPP-4 inhibitor and, of course, a statin, which all these patients should be on. So the question then really is, what more can the GP do? And I'm not sure there is anything obvious, except that this patient would have got into the Credence study. So we'll move on to the study in just a second. In terms of classification of CKD, and with great respect to my esteemed colleagues this morning, I just wanted to do a quick CME on CKD classification just to tighten up the definitions just a little bit, because the terminology this morning wasn't perhaps as tight as it could have been. We talk about chronic kidney disease rather than chronic renal failure. Failure does not have a good connotation for a patient. We classify by GFR and by albuminuria based on the spot albumin to creatinine ratios. So here are the GFR stages. Here are the albuminuria stages. You don't have CKD if you have a GFR of greater than 60 and no albuminuria, unless you have a structural abnormality to your kidney. You do have CKD if you have GFRs in this range with albuminuria, assuming that albuminuria has been present for at least 3 months, giving you chronicity. And you do have chronic kidney disease if your GFR is less than 60. And you'll see here that certainly in these middle ranges, stage G3A CKD, stage G3B CKD, the risk, which is depicted in the colors in this chart, is increased at higher levels of albuminuria. So this is pretty useful for us in primary care, where most of these patients sit. If they're non-albuminuric, they're at low risk. If they're albuminuric, they're at high risk. This is risk of progression of chronic kidney disease, risk of cardiovascular events, risk of acute kidney injury, risk of unexpected hospital admission, unplanned hospital admission. Whatever you like, the more albuminuria you've got at a given level of eGFR, the higher the risk. Our patient sits in this box here. He had ACR of 65, GFR of 39, G3BA3, and he's at high risk of poor outcomes. And as I said, he would have got into the Credence study. So this was a study of patients. Sorry, before I go there, the hint I think we got before starting Credence was from the cardiovascular outcome trials that you'll be familiar with. EMPA-REG, CANVAS, and the DECLARE studies. And these studies, of course, were cardiovascular safety outcome studies. But the investigators collected some kidney data in these trials. And some of these analyses were post hoc, and not all were pre-specified. But we were getting a signal from these cardiovascular outcome trials that these drugs may have kidney benefits. A hodgepodge of different renal outcomes, mainly combinations, very few patients reaching end-stage kidney disease in these studies, because all the patients going into these studies, by and large, had GFRs of greater than 30, and certainly in the DECLARE study had a GFR greater than 60 by Cockcroft-Gault. So these patients had well-preserved kidney function when they went into these studies. And you saw this slide this morning from Professor Marks. Patients going into DECLARE, CANVAS, and EMPA-REG, by and large, had normal levels of kidney function. So mean eGFR was above 60, and the median urinary ACR was below 3. So these patients fit into this group here, top left corner. Very few renal endpoints, if you like, dialysis, transplantation, or death due to untreated end-stage kidney disease, which we've called renal death here. By comparison, Credence recruited the sort of patient I've just shown you, and this is reflected in the fact that there were far fewer end-stage kidney disease events in the Credence study compared to the prior trials. So Credence recruited a much higher risk population of patients, the sort of patients that nephrologists look after. So inclusion criteria for Credence, over 30, here are the HbA1c criteria. You needed an eGFR between 30 and 90 and albuminuria. You needed to be on the maximum tolerated dose of an ACE or ARB, and we up-titrated these drugs before we randomized the patients, and then a few exclusion criteria over here. 2-week run-in, 1-to-1 randomization to canagliflozin, one dose, 100 milligram, or to placebo. Follow up at 3 weeks to look at acute effects on eGFR. We'll come back to that, and then regularly thereafter. And importantly, patients who were recruited with an eGFR of greater than 30, who subsequently dropped to an eGFR of less than 30 during the trial, stayed on their study medication until they reached dialysis or had a kidney transplant. So we do have some exposure of patients to the drug at GFRs between 30 and 15 or starting dialysis. So these were our objectives. We wanted to study a high-risk population with CKD who were receiving standard of care, including maximum ACEs and ARBs. And our primary endpoint was a composite. It's a renal composite, if you like, of end-stage kidney disease, doubling of serum creatinine, and death due to untreated end-stage kidney disease, so renal death. But because many patients with end-stage kidney disease die of cardiac arrhythmias, thought perhaps to be a cardiovascular death, we wanted to capture cardiovascular death as well in our primary endpoint. So if you don't dialyze a patient, they drop to an eGFR of virtually nothing and then die of a cardiac arrhythmia. They are captured in this primary endpoint. And then a number of secondary endpoints here, including cardiovascular outcomes, which I'm not going to focus on today, and of course, other combinations of these renal endpoints. Okay, so 4,401 patients randomized, equally to placebo and canagliflozin. Most patients stayed on study drug, and you can see here that we knew the vital status of all but 5 patients at the end of the study. So we only lost track of 5 patients, and we didn't know whether these 5 were dead or alive. For all other patients, we knew the vital status. Mean age of around about 63. Let's look at the totals here. Mainly male. This is typical of this population of patients with chronic kidney disease, always more men than women. 16 years worth of diabetes, all were hypertensive, some had heart failure, and 50% had prior evidence of cardiovascular disease. So if you're looking at primary versus secondary prevention, this is a 50-50 study. We'll come back to that in just a minute. We, of course, got worried about amputation during the study, and we had recruited 5% of patients who'd had a prior amputation. So here are the diabetic drugs that these patients were on. Insulin, let's go here, insulin, metformin, DPP-4 inhibitor, very little use of GLP-1 receptor antagonists. All but 6 patients were on RAS inhibitors. 2/3, but not all, were on statins, and various other combinations, including loop diuretics. This is all diuretics, but some of these patients here were on loop diuretics. So did this drug have the expected metabolic effects in patients with chronic kidney disease? And the answer's pretty much yes. So here are HbA1cs, canagliflozin in blue, placebo in orange, HbA1c percent, and time of exposure during the study. And the mean HbA1c reduction was 0.25%. You can see acute drop early on, followed by a rise in the canagliflozin treated group, because investigators were free to juggle all those other oral hypoglycemic agents in these patients in an effort to control glycemia. And that's probably why this placebo line comes down during the study. As the patients spend longer in the study, the investigators get a better grip on glycemic control. So these come together towards the end of the study, I guess indicating that the investigators were doing a pretty good job of managing diabetes. But a 0.25% difference, time averaged across the study for HbA1c. Perhaps not as big as we would have expected from studies of these drugs in patients with better preserved kidney function. And yes, we saw the drop in blood pressure. This is systolic, 3.3 millimeters of mercury, a useful drop in systolic blood pressure favoring the canagliflozin as opposed to the placebo group, and sustained throughout the follow-up period. And also a reduction in body weight, 0.8 of a kilogram, not enormous, but again sustained during the course of the study. So these drugs in this population of patients with chronic kidney disease did what we expect them to do from studies in other populations with better preserved kidney function, except perhaps that reduction in HbA1c was not as big as we've seen previously. So here's the primary outcome. The composite of end-stage kidney disease, doubling of serum creatinine, or renal or cardiovascular death. This is time to first event, Kaplan-Meier analysis. And you can see here divergence of these lines at 12 months, 30% reduction with a nice p-value there. And you saw this graph this morning. So did the baseline kidney function matter? Did patients perhaps benefit more if they had better kidney function? And the answer is not really. So here are the baseline GFRs. This is the primary endpoint stratified by the baseline eGFR and the baseline urinary albumin to creatinine ratio below 103 milligrams or above 103 milligrams. That's the median. And you can see here pretty similar results in the forest plot with p-values for heterogeneity that are not statistically significant. So these results are statistically comparable. No suggestion that they're different. This is perhaps a more relevant outcome for the patient. This is starting dialysis and staying on dialysis for more than 30 days, receiving a kidney transplant, or having an eGFR drop below 15 and staying below 15. So this is the time when we start thinking very hard about dialyzing patients, although of course not all are dialyzed. And for this outcome, you can see again a statistically significant reduction in this endpoint, 42% reduction. So, what happened to GFR during this study? I've just realized that that's a 32% reduction, excuse my maths. So what happened to eGFR during the study? Well, let's just have a look. In the initial stage of the study, so remember there was a 3-week blood sample. In the initial stage of the study, there was an acute decline in eGFR that was greater in the patients randomized to canagliflozin. So this is a 3.72 ml per minute reduction in eGFR, a small reduction in placebo. If you then look over time, there's a crossing over of these two lines at 12 months, such that in the longer term, the patients receiving canagliflozin had a slower progression of their chronic kidney disease. So acute drop followed by slowing of rate of progression over time. And these are the slopes. And you can see here that this is a useful change in the rate of decline of eGFR, potentially delaying the point at which these patients would need dialysis. So what's going on here? Well, you may remember that this is exactly what we saw or see with ACE inhibitors and angiotensin receptor blockers. We see an acute drop in eGFR followed by stabilization with a benefit favoring the ACE and ARB versus the placebo agent in the trials. And we saw this kind of relationship in trials like Renal and the IDMC study way back 20 years ago now. So there's something about this acute drop that marks out a drug that may well be beneficial in the longer term in terms of kidney function. How about other adverse events? This is renal safety. All renal adverse events. This is the right way round, favoring canagliflozin rather than placebo. And this trend towards fewer acute kidney injury events in the canagliflozin group compared to the placebo-treated group. So despite that acute decline in eGFR that I just showed you, these patients are not developing more acute kidney injury. And no problems with hyperkalemia either. So from a renal perspective, we're reasonably happy. After the Canvas data, which came out partway through Credence, we were, of course, very worried about amputation. Remember, 5% of these patients had prior amputation. The risk for amputation in this patient group was higher than in the Canvas trials. Remember the demographics of this patient population. But we saw absolutely no signal in terms of lower limb amputation in the trial, which was hugely reassuring. We did see the expected side effects. We saw increased mycotic infection of the genitalia in patients on the drug compared to placebo. We saw no increased risk of bacterial urinary tract infection. We had 12 cases of diabetic ketoacidosis, of which 11 were in the canagliflozin group. So there's a problem with diabetic ketoacidosis. But as I say, no problem with amputation risk. So if you manage these patients, you might want to know how many patients you would want to treat for 2.5 years, the follow-up period of the study to prevent an event. This is for the renal and cardiovascular outcomes. Primary composite here, 22 patients treated for 2.5 years to prevent one event. And with the current price of these drugs, this could easily be cost-effective, and we're obviously doing a cost-effectiveness analysis based on these data. And then you can see the other endpoints here, but useful reductions without needing to treat hundreds of patients. So just putting the credence result in a meta-analysis with the results from DECLARE, CANVAS, and EMPA outcome. This is for dialysis, transplantation, and renal death. Of course, far more events in credence. You've got a bigger box. But by and large, all these results line up. No significant heterogeneity. And here's the overall point estimate. So all the results of all these studies from the renal standpoint kind of line up together. Now, I know I'm meant to be talking about nephroprotection, but of course we saw cardiovascular events in the credence study. And as you heard this morning, in this group of patients with chronic kidney disease, we saw the cardiovascular benefits. So we saw a reduction in MACE, and we saw a reduction in heart failure hospitalizations. So not only do these drugs prevent progression of kidney disease in this population, they also reduce the risk of cardiovascular events. And what we've done here is we've divided these patients according to whether they had a prior event or not. Remember, this was 50-50. And you'll see here that in the primary prevention setting in credence, we are seeing a benefit favoring canagliflozin, which it doesn't always reach statistical significance. But certainly the trend here is towards a cardiovascular benefit in both the primary and the secondary prevention setting in this trial, unlike the cardiovascular outcome trials I showed you at the beginning, in which the benefit was clearest in those patients who'd had a prior MACE event, as you'll recall. So that may not apply to this population. As I say, we're seeing benefits whether or not there was a prior obvious cardiovascular event on entry or prior to entry into the study. So the other question is, do these drugs work to prevent progression of chronic kidney disease in patients who don't have diabetes? So might these be drugs for patients with chronic kidney disease who are not also diabetic? We don't know that from credence because all our patients were diabetic. But we have done this analysis which looks at outcomes by baseline HbA1c. So if you like, this top group here for these three outcomes are the patients who have the least severe diabetes, or the best diabetic control, you could argue, at the point of entry into the study. And you'll see here that, again, there's no heterogeneity. So no suggestion that the patients who have the better controlled diabetes do any worse or any better in terms of benefits than those who have the more poorly controlled diabetes. And that's as close as we can really get in credence to studying a patient population who do not have diabetes. But there are two trials going on that will address this question. So the DAPA-CKD study has recruited patients with eGFRs down to 25. The EMPA kidney study, you can imagine dapagliflozin and empagliflozin, is recruiting patients down to an eGFR of 20. So each new trial is digging deeper into chronic kidney disease and allowing us to gain some evidence in patients who have more severely impaired kidney function. So the DAPA patients need to have albuminuria. The EMPA kidney patients don't need to have albuminuria if they're in this lower eGFR range. So this study will recruit patients with low eGFRs without albuminuria, and both studies are recruiting patients with and without diabetes. This study will be the first to read out sometime, we believe, in 2021. Okay, so what you're going to ask me is, how do these drugs work? And I'm going to tell you a story in the last few minutes that you may or may not want to believe, but it's the best we can do at the present time. Okay? So see if you believe this. This is tubular physiology. All the nephrologists in the audience will be totally familiar with this, of course, as the rest of you may well be. This is the juxtaglomerular apparatus and the macula densa here. So each glomerulus drains into a tubule, and this tubule touches back to that same glomerulus. There's a contact between the tubule that's drained by this glomerulus and the glomerulus in this area of specialized cells called the macula densa. So this is called the tubular glomerular apparatus, and the area of interest is the macula densa. So here, the filtrate can control the function of the glomerulus, and it does that by modifying the tone of the afferent arteriole. This is the infeed to the glomerulus. So this is the normal physiological situation. We are filtering sugar and sodium. Some sodium and sugar is taken up by the SGLT2 co-transporter in the proximal tubule, but sodium is delivered to the distal tubule. We go to the bigger diagram. Here's sodium delivered to the distal tubule. Here's the sodium-potassium 2-chloride co-transporter taking the sodium up into the macula densa cells just here. This leads to a cleavage of ATP to AMP. The AMP generates the production of adenosine. Adenosine feeds to the mesangial and vascular smooth muscle cells that maintain the tone of the afferent arteriole. So in normal situations, there is adenosine signaling and maintenance of a basal tone of the afferent arteriole here. Okay? Okay so far? Right, this is diabetes. Okay? We have upregulation of the SGLT2 co-transporter because we have glycosuria. Okay, so the kidney is compensating for the glycosuria by taking up more glucose, but also takes up more sodium in the proximal tubule, leading to a decrease in sodium delivery to the distal tubule. Signaling pathway switched off, no basal constrictor tone in the afferent arteriole, which vasodilates. More blood coming into the glomerulus, higher pressure in the glomerulus, potentially glomerular damage from higher pressure and hyperfiltration. Add in the SGLT2, and of course you restore the normal physiology with less glucose and sodium uptake, delivery of sodium back to the macula densa, and switching on the signaling system that leads to adenosine secretion and through increases in intracellular calcium, restoration of afferent vasoconstrictor tone. I told you it was a story. You can believe it if you're not. What it does do is it nicely explains the acute effects of SGLT2 inhibitors. So here's RAS blockade. Here's the glomerulus, the afferent arteriole, the glomerular tuft, the efferent arteriole. Here is RAS blockade, blocking angiotensin II vasoconstriction of the efferent, leading to efferent arteriolar vasodilatation. Dilatation of the outflow leads to a lower pressure in the glomerulus, protecting the glomerulus, reducing filtration, reducing the driving force that leads to albuminuria. Okay, remember all our patients in Credence should have had this system switched on already, so what we believe we might have then done is constricted the afferent arteriole with the SGLT2 inhibitor, further reducing the intraglomerular pressure, further reducing albuminuria, and I didn't show you the data, but albuminuria goes down, and hopefully further protecting kidney function. So I hope that makes sense, but I think this is the best explanation as to why these drugs work on top of ACEs and ARBs and why we see that acute drop in EGFR. Finally, this is for Cliff. Okay? When can we use these drugs in terms of patients' kidney function? Well, this is current licensing in Europe, okay? So for these drugs, if GFRs are above 60, we're going from 90 here to 30 here. Above 60, use what you like, whatever dose you want, no problems. GFRs between 60 and 45, use the lower dose of these drugs. Do not initiate treatment. GFRs below 45, do not prescribe and stop treatment if patients are on them. Why? Because these drugs lower HbA1c. I didn't show you the data, but I hinted at it. In these patients with poorer kidney function, we see less of a reduction in HbA1c. These drugs work via the kidney's not working, you don't see the same reduction in HbA1c. So for what these drugs were designed for, which is to lower HbA1c, they don't work as well down here, so the view was that they shouldn't be prescribed. Of course, Credence has now changed this, And at least in the US now, the FDA have granted canagliflozin in the license across this range of EGFRs. We are not there yet. Hopefully, we will be in a few months' time. So take-home messages. Thank you for listening to me.